Do you want a recap? Anyways, just take a recap so that you will refresh. So in renal calculi, that is renal stones, you saw that it is more common in males, and the clinical features will be pain, right, located over the renal angle. They can have pain where and all in the hypochondrium and in the lumbar region. The pain will be radiating to groin and testis in males. And you saw that there could be ureteric colic, again pain, hematuria can be there, pyuria, that is pus and urine, can be there. There can be fever. In signs that you will see that there is tenderness in renal angle, there can be mass in the loin, which we have explained the details of the type of mass, and there can be guarding or rigidity. These people can have urinary tract infection, and you may also have hypertension in these people. Okay, so this is the renal angle, guys. You have looked at all this in the previous video. Now coming to the etiology of renal stones, you saw that diet, vitamin A deficiency, or foods that are rich in oxalate. If you are living in a hot climate, this will lead to increase, urinary solutes will increase with decrease in colloids. Then there can be decrease in citrate level, which can lead to stone formation. There can be infection in kidney because of E. coli, Streptococcus, Staphylococcus proteus, leading to renal stones. There can be prolonged immobilization, which can cause decalcification of the bones, and there can be hypercalciuria, leading to stone formation because calcium is pulled out of the bones during immobilization prolonged. Then metabolism like hyperparathyroidism, gout, hyperoxaluria, cystinuria, all these can be leading to renal stones. Then you saw that if there is obstruction to urine flow, then there will be stasis of the urine, which can lead to formation of stones. Then you saw that there is some Randall plaque theory, which explains that there can be erosion, some kind of ulcer in the renal papillae. So whenever there is this kind of erosion or an ulcer that develops in the tip of the renal papilla, there can be some deposition of calcium. So minor calcium particles can get deposited, and that can lead to stone formation. This much we have seen. We saw the stages of stone formation like supersaturation, nucleus formation, crystallization, aggregation, matrix formation of stone. Just the names we looked at. Then we looked at the types of renal stones. We saw 4 types. We saw the calcium oxalate stone, also called as the mulberry, which is a common type of stone. It has sharp projections. It can produce hematuria. It occurs in infected urine, right? And it will be radio opaque. You can actually see it in KUV X-ray. Did they use the word radio opaque here, or are we saying that? Okay. Then coming to uric acid, guys, uric acid stone, look at this, yellow, it is multifaceted, small they are, and these are radiolucent if they are pure uric acid, and they will occur in acidic urine. People who eat red meat will have this type of stone, and because they are soft and all, they are more responsive to lithotripsy, where you break the stones, okay. Then phosphate stones, guys, focus, what are you looking at? We are looking at the recap of all the previous videos on this topic. So basically you saw phosphate stones, also called as staghorn calculi. So these will be smooth, round, and there will be triple phosphate of calcium, magnesium and ammonium. They are dirty white to yellow in color. They will be in alkaline urine, right? And the photo for staghorn is this, staghorn calculi, dirty brown, yellow and all that, dirty white to yellow, okay. Then let's go to the last type, cystine calculus. Cystine calculus, they didn't give any photo as such, but this will occur in young girls at puberty. There will be an inborn error of metabolism of cystine, is it? So there will be cystinuria. There will be decreased absorption, decreased reabsorption of cystine from the renal tubule. So where will the cystine be? In the urine. So cystinuria will be there. They will get cystine calculus. So what else? So these stones are very hard, right? They are hard and they are radio opaque. Why? Because they have sulfur. So these are hard. That's why in extracorporeal shockwave lithotripsy, they do not prefer that procedure for cystine ones, because cystine ones are hard. Cystine calculi are hard, guys. We're just taking a recap. So if there is one type of stone growing on another type of stone, you saw 4 types of stones. In that one type of stone growing on another type of stone is called as epitaxy. And there are a lot of other types of stones, guys, like xanthine stones, and there is another term, struvite, is it? Struvite stones is the same thing. They are saying triple phosphate stones, tips, okay. What are the complications of renal stones also we looked at, guys? So what are the complications? There can be ureteric stones, isn't it? So ureteric stones come from where? From the kidney itself, kidney stones. But I don't know if it's exactly a complication, but the actual complications you'll have to write is hydronephrosis, which is swelling of the kidney because of a blockage, outflow, obstruction to the flow of urine. So there will be backflow causing hydronephrosis. Pyonephrosis, when there is pus, right? And renal failure can happen, especially in this phosphate, staghorn stones. Basically, what will happen is, these people will be asymptomatic. Finally, they will present with uremia, that means urea in the blood, right? That means the kidney is not doing its job. So finally, you will come to know that they have renal failure, okay? Squamous cell carcinoma, long-standing stones will increase the risk of carcinoma. So these people can even get cancer, carcinoma, you can say. Okay, so those are the complications. So what investigations you will do for these people? You will check the blood urea levels and the blood creatinine levels. You have seen the normal values of urea around 13 to 42, creatinine 0.6 to 1.1. So blood urea and creatinine will tell you how the kidney is functioning, right? Then you will do a plain X-ray, KUB, that is kidney, ureter, bladder. Then you will, most of the stones you will be able to diagnose in this itself. You can do ultrasound, right? Ultrasound will also give you the exact location of these, because it's a more like a three-dimensional kind of a thing, right? USG. This X-ray is more like a 2D. IVP, intravenous pyelogram, you can do, which is nothing but contrast. It uses contrast in X-ray. This again will tell you the exact location, right? And then if there is something which is, focus guys, if there is something that you cannot get in an X-ray because it's radiolucent, then you can still get it in an IV pyelogram, because it will show you filling, how the filling is happening. If there's a filling defect but you don't see anything there, that means there is a non-radio opaque, that means radiolucent stone, is it? Okay. Then you can also do a non-contrast CT scan or a contrast CT scan. Remember, CT scan we have seen in many hospitals. As soon as they suspect kidney stones, they're doing CT scans costing about 10 to 15,000 rupees, isn't it? Then urine, again, you're checking, you checked blood, you did X-ray and your ultrasound and etc. etc. You'll also have to check the blood. Blood for what, guys? You'll have to check, sorry, what am I saying? You'll have to check the urine also for culture and sensitivity, to find out if there is UTI. So these some X-rays we looked at. Then we came to treatment. In treatment, what and all did we see, guys? We have covered this non-operative treatment. Basically, conservative treatment, if it is less than a 5 millimeter stone, they'll do flush therapy. They'll just give so much water to drink or something, right? Drink a lot of water, and you also can give IV hydration and IV furosemide to have some forced diuresis, so that this person will flush out these stones which are small, right? Along with this, they can give a lot of other things like, wait, I'll tell you. See, with flush therapy, you should also give antispasmodic or something they're giving. Spasmodic. Because otherwise what will happen, you know? These people will have pain, then who will take care of the pain, right? Anti-inflammatory also they're talking about. Inflammatory. IV furosemide, how much will you give? 60 to 80 mg they are giving, okay. Anyways, if you can remember all this. Then we looked at extracorporeal shockwave lithotripsy, ESWL. Basically, I told you already, we cannot use it for cystine stones because cystine stones are hard. So this extracorporeal shockwave lithotripsy looks, they are putting this kind of a DJ stent. So look at this. Extracorporeal shockwave lithotripsy. The shockwaves are coming from outside the body. So look at the photo, then only you will understand. So there's a C-arm kind of a thing here. There's nobody here on this bed. But then now here you can see there's a patient here, and the C-arm is sending the shock waves, right, to do lithotripsy, that is to break the stone into smaller fragments, right. So this is called as some Dornier lithotripster, if you want to remember. This is a C-arm. Then what else you should know here? What is the shocks produced at 2 per second? Per second they are giving 2 shocks, is it? And 1,000 to 4,000 shocks are required for each stone. All this you can see, the shock waves, how are they passed to the stone? Through water bath or water cushion. Where is that? So much details we have looked at everything in detail, guys. Look at that in the previous video. Then we looked at the advantages of this ESWL. No anesthesia is required. You can do it as an OP procedure. Then you can eliminate oxalate stones, etc. And you can do it in repeated different settings. If it is not successful, then you have to go to PCNL, that is percutaneous nephrolithotomy, that will come to. What are the complications of this EWSL? It can cause hematoma, hematuria, injury to adjacent structures. You can still have some stones retained in the ureter. Contraindications, don't do it in people who are pregnant or have bleeding disorders. And if a person is having the abdominal aneurysm, because they can have bleeding, etc., right, you can injure it. So be very careful. In those people you don't do. And sepsis and renal failure also they are not doing. Guys, we are taking a very detailed recap. Okay, just look at this. This is the DJ stent, that is double J stent. So they have placed a stent. Okay, once they give the shock wave and all these the stone will become fragment. Those fragments will come out through this stent. Okay, it's a double J stent. That's it, guys. So you have looked at extracorporeal shockwave lithotripsy. But if this fails, or if you have other types of stones, then you can do laser lithotripsy. We are using holmium YAG laser. Basically, this you can use for all types of stones. Then what happens? There is another condition called a stone street. Basically, what happens? These stones that are coming out, right? They can block the distal end of the ureter. That is called as Steenstrasse. Okay. So, like, if this extracorporeal shockwave lithotripsy is not working, then you'll have to move on to PCNL. That is percutaneous nephro-lithotomy. Actually, it is coming under endoscopic procedures. Look at this. What you will do here, you will go via the skin, isn't it? And you will pass a guide wire, then a nephroscope, and you just remove the stone. As simple as that. Okay. So either you have a stone or a fragment of a stone after all these procedures. You have to pick up those stones. That's it. That's what you're trying to do here. So you're going to do 1 centimeter incision in the loin. You will put the PCN needle into the pelvis of the kidney, and you will confirm this by fluoroscopy. You will pass a guide wire through the needle into the pelvis, okay, of the kidney. The needle is withdrawn. Then, with the guide wire left within the pelvis, dilators are passed over the guide wire and a working sheath is introduced into the pelvis. A nephroscope is passed into the pelvis, and if stone is small, it can be taken out. Okay. If it is big, you'll have to crush it and take it out. Okay. So again, in this, what are the indications? Which are stones which are smaller than 2.5 centimeters in size, you can remove. Multiple stones, and then some things which are not responding to ESWL, you can use this. Complications, again, here you have hemorrhage, perforation, injury to surrounding structures, etc. So, did you understand? This is using nephroscope, and you are actually going into the skin, and you are making a procedure. So, this is coming under operative treatment. Under that, it is coming under endoscopic procedure. So, now let us go to open procedures, guys. So, till PCNL you have finished actually. Now let us go to open procedures. This is what we want to look at. So you have pyelo-lithotomy, nephro-lithotomy, extended pyelo-lithotomy, pyelo-nephrotomy. So they combine both of these, pyelo-nephro-lithotomy. Partial nephrectomy. Nephrectomy, you can understand, removing a part of the kidney or the kidney. Okay, so now let us look at lithotomy. What is lithotomy? Removing the stone, right? Pyelo, nephro. What is pyelo-nephro? What's the difference? So depending on the location of the stone, you have different procedures. Just let's look at some photographs to understand. So if you look at these two, just look at these two images, A and D. A is actually pyelo-lithotomy and D is nephro-lithotomy. So just look at this. Pyelo is more in the pelvis and nephro is more in the parenchyma, kidney parenchyma. Okay. So pyelo-lithotomy is where it is extra-renal pelvis. So, extra-renal pelvis this is. Nephro-lithotomy is when there is intra-renal pelvis. The stone has to be taken out through the kidney parenchyma. Okay. Then, extended pyelo-lithotomy. Where is that? This one. Extended pyelo-lithotomy. Guys, how's it going? Is it becoming too much? Okay, what are we looking at? Pyelo-lithotomy over, nephro-lithotomy over. Now we are going to extended pyelo-lithotomy. So let's understand by this. See, this is kind of inside but outside the kidney parenchyma. By retracting the kidney parenchyma laterally, the incision over the pelvis can be extended over to the calyx and the stone can be extracted from the calyx. Even a large staghorn calculus can thus be removed. So this is more like a extended pyelo-lithotomy, if you understood. Then pyelo-nephro-lithotomy. Where is that? Pyelo-nephro-lithotomy is this one. They have written nephro-pyelolithotomy, pyelo-nephro-lithotomy. They keep interchanging it, is it? So look at this. The stone is extracted through an incision in the pelvis as well as the renal parenchyma. So where is the incision? Two places. It is in the pelvis as well as the renal parenchyma. Are you able to see any incision here? Is this an incision that they are talking about? Okay. So this one is representing a pyelo-nephro-lithotomy. Correct, right? Good. Then next, let's go to the nephrectomy. See, this one you understood. Pyelo-lithotomy, pelvis somewhere. Nephro-lithotomy, intrarenal pelvis, you will have to be taking it out through the kidney parenchyma. Extended pyelo-lithotomy, you saw that you will retract the kidney parenchyma laterally, incision is made over the pelvis and you can extend it over to the calyx and the stone can be extracted from the calyx. Then pyelo-nephro-lithotomy, the stone is extracted through the incision in the pelvis as well as the renal parenchyma. Two places they are putting incision. Looks like pyelo-nephro-lithotomy. So all lithotomies are over. We are finally reaching nephrectomy. You are removing a part of the kidney, partial or nephrectomy. So what is this partial nephrectomy, guys? Take a deep breath, guys. We are looking at open procedures for renal stones. Okay. Take a break, guys. We are looking at the treatment of kidney stones. Okay. So let's continue with partial nephrectomy. So the name itself is very clear. So you're going to remove a part of the kidney. When the stone from the lowermost calyx is impacted, a lower pole nephrectomy can be done. So when it is lower pole and the stone is kind of impacted, they're talking about a lower pole nephrectomy. Okay, let us see the photo for this. Yep, so this is nephrectomy, partial. Now when are you going to do nephrectomy? That they didn't put photo. When the kidney is destroyed by pyonephrosis following obstruction by stone. So basically if it is full of pus and pyonephrosis, then they are talking about removing the kidney. That is nephrectomy. Okay, there is one thing here, that is coagulum pyelo-lithotomy, which we have not looked at. It's not there in the textbook in Manipal. But basically here I will just tell you what exactly it is, guys. This one, coagulum pyelo-lithotomy. Basically here a coagulum solution which contains fibrinogen is poured into the renal pelvis. You're pouring something into the renal pelvis, some coagulum solution. Okay, it is activated so that it solidifies. Then this will go inside and it will solidify. So it will entangle all the stones in the renal pelvis and then you will remove this entangled mass. How? Wow. So you're putting something here, it is entangling all the stones. Sounds like some bubble gum. You put some bubble gum and all the stones are sticking to that bubble gum and then this bubble gum will become hard and they're removing that, is it? Coagulum pyelo-lithotomy. Lithotomy. Why? Because you're just bringing the stones out. Okay. Then there's one more thing, guys, in the textbook called as bench surgery. So what is this bench surgery? Bench surgery is because the kidney is removed out temporarily, cooled by ice packs, stones are searched and removed and then you're replacing the kidney. Wow, that is bench surgery. Strange, isn't it? So let's make a note of that. So let's just add some things here. E was coagulum pyelo-lithotomy. This is that bubblegum kind of a thing. Then one more thing we learnt was you do some bench surgery where you remove kidney, remove stone, put back kidney, which really is crazy to hear, isn't it? You will remove the kidney, you will cool it with some ice packs and then you will search for stones, remove the stones and put back the kidney in the right iliac fossa. Then you saw partial nephrectomy and nephrectomy. Okay, now we have to go to something called as special situations, which is there in another textbook. Okay guys, so let's look at special situations. Do you want to look at the happy kidneys? Here they are. So what are the special situations? They are very excited to learn. With this bilateral kidney stones, kidney with better function has to be operated first. Why will they operate the kidney with better function first? Interesting. So if this bilateral kidney stones operate on better kidney first. better functioning kidney has to be operated first, and then after 1 or 2 weeks you can operate on the opposite side. Okay, if there is pyonephrosis with severe degree fever, then nephrostomy is done and drain tube is placed. So there is something called as nephrostomy also. Nephrostomy you will do whenever there is pus, isn't it? So you can drain the pus with the stomy. You kind of create an opening. Then, that's it, only 2 special situations, is it? So once you remove all this pus, then you will assess the kidney. You will check if the kidney is not functioning, then you will do nephrectomy. If the kidney is functioning, you want to save it, you will try to remove the stones. How? By ESWL, PCNL or open procedure, etc. So, this is actually called as percutaneous nephrostomy. If pus was there, okay. So this procedure is called as percutaneous nephrostomy. If pus has to be drained, no, they will do this. So we are done, guys, with all the treatments of renal stones. Basically, understand, guys, that these open procedures have actually become obsolete, it seems. Now, so whatever you have learnt in this video is totally obsolete. Okay. So anyways, these things are obsolete, but you have to write it in exam. And kidney stones or renal calculus is such an important question for you that it is better you know all these terms. Okay. So it's a very important question, guys, for you, this kidney stones thing. Combining textbooks and learning is quite difficult, but anyways, before this bench surgery, just learn one more thing called as AnATROPHIC Pyelo-lithotomy. So this is also lithotomy, but understand this is AnATROPHIC Pyelo-lithotomy. Basically here what they're saying is you expose the kidney, you cool it with ice packs, okay, then you clamp the renal artery temporarily. Then what you will do is, kidney is opened through this Brodell's line and stones are removed. So this is another type of, I would say, expose kidney, open kidney, remove stones. So this is something that is to prevent atrophy, AnATROPHIC Pyelo-lithotomy. So anyways, everything is obsolete. These open procedures are obsolete, they are saying, but examination wise you have to say. Now let's revise all the open procedures. Come on, say all the lithotomies. Come on, let's see. Yes, you can say all the lithotomies. Yeah. Pyelo-lithotomy, nephro-lithotomy, Pyelo-nephro-lithotomy, extended Pyelo-lithotomy, very good. Coagulum lithotomy, very good. Then you learnt AnATROPHIC lithotomy, very good. Now coming to all those procedures where you're trying to remove the kidney. Okay, you saw partial nephrectomy and nephrectomy. Before that you saw some bench surgery, right, where you're trying to remove the kidney and actually you're removing the kidney and then you're removing the stones and putting the kidney back. So yes, so we have covered all these in our revision, very good. Special situation, bilateral means you'll operate on the better kidney first, and nephrostomy you will do whenever there is pus and you want to drain the pus. Okay. So that's it, guys. In this video you have looked at treatment, especially the open procedures you have looked at in this video. Bye bye.